Hi everyone, my name is Margaret Murdoch. It's December 17th and this is my Unit 4 Case Connections presentation. I do have a bit of a cold, so I apologize in advance for some of the audio quality. To get into this, I'm going to start with Case 2. So for the first scenario, we have a full-term healthy baby who had a normal birth and was released from the hospital at 3 days of age. At 9 days of age, this baby did screen positive on a test for branched-chain amino acids. So tests to identify branched-chain amino acids are most commonly used to identify the presence of alloisoleucine, which would be used to rule in or out a condition called maple syrup urine disease, or MSUD, as I'll be referring to it. So MSUD is a type of metabolism disorder that occurs during the neonatal period and is often detected shortly after birth and is caused by defects in the branched-chain alpha-keto acid dehydrogenase complex. And this results in elevations of branched-chain amino acids in plasma, alpha-keto acids in urine, and the production of characteristic disease markers like alloisoleucine. MSUD is characterized by a deficiency of the enzyme complex branched-chain alpha-keto acid dehydrogenase, which is an essential component for metabolizing branched-chain amino acids like leucine, isoleucine, and valine. Because MSUD impacts the ability to break down branched-chain amino acids like leucine, isoleucine, and valine, as well as their toxic byproducts, these things can build up in the system because the body's unable to break them down and remove them. There are some potential vitamins and supplements that can be useful for managing this condition. Specifically, taking supplements of isoleucine and valine can help manage it. Additionally, high doses of vitamin B1 or thiamine can help manage thiamine-responsive MSUD and is in help with the part of the metabolic process where branched-chain amino acids are broken down. In addition to supplement addition, dietary changes can be used to manage the effects of MSUD, like limiting the intake of amino acid-dense foods like meat, dairy products, as well as like legumes, beans, chickpeas, things like that. Doing that can help prevent amino acid buildup as well as prevent metabolic crisis. To get into the second scenario, we have a 69-year-old woman who presented with a 30-year history of lower back and large joint pain of the hips and shoulders, as well as blue-gray pigmented macules, and she has a history of aortic stenosis. So given her presentation and medical history, I would anticipate that she's suffering from a condition called alkaptonia. Although her lab tests weren't included in this scenario, this is something that would be ruled in by testing for elevated levels of urine homogenistic acid. So alkaptonia is an autosomal recessive disorder and a deficiency of homogenistic acid oxidase, which results in the buildup of homogenistic acid in the connective tissues. This accumulation results in the development of those blue-gray pigmented macules that she presented with, as well as cardiac valve disease, both of which are consistent with her symptoms and her medical history. Alkaptonia results in the inability to break down amino acids like tyrosine and phenylalanine, which is the cause of this homogenistic acid buildup. So there are some potential vitamin supplements that can be helpful for managing this condition. Research has found that nitazone, as well as vitamin C and absorbic acid, can all be useful in managing alkaptonia. Absorbic acid serves as an antioxidant in this case, and it helps to slow down the conversion of homogenestase to polymeric material, which is deposited in the cartilage and contributes to some of the symptoms of this condition. Getting into the third scenario, we have a 4-day-old infant who's being followed up. It had a low but normal birth rate and a normal birth, but screened positive for elevated levels of phenylalanine following birth. So elevated phenylalanine levels in newborns can indicate hyperphenylalemia, which is caused by the enzyme phenylalanine hydroxylase functioning improperly. And when phenylalanine hydroxylase breaks down the amino acid phenylalanine, which leads to the elevated levels in the blood when it's not functioning properly. So this condition impairs the ability to break down the amino acid and is related to a defect in the PAH gene. Tetrahydropropene is an essential cofactor for the PAH, as well as for phenylalanine hydroxylase, tyrosine, and tryptophan hydroxylase reactions. So it's involved in a lot of really important metabolic reactions and processes. Research on vitamin supplementation for this condition is pretty inconclusive. There have been some studies that have assessed the functionality of a controlled diet with really strict macro and micronutrients in managing levels of protein, calcium, phosphorus, B12, ferritin, and zinc. And all of these levels were normalized with strict adherence to the controlled diet, although pre-albumin and selenium levels were actually reduced. So it's unclear what supplementation is the best course for treating it, although it seems like there is some promising research happening. The next case that I'm going to be presenting on is case 4. So we have a 58-year-old woman who presented to the emergency department with progressive fatigue and weakness, shortness of breath, mild diarrhea, as well as numbness and tingling in lower extremities, and a loss of balance. Although she's denying any other neurologic or cardiac symptoms, physical exam did reveal tachycardia, as well as decreased sensation. She also had a systolic murmur and a rapid regular heart rhythm. So the suspected diagnosis here was megaloblastic anemia. There were a number of suggested deficiencies that might contribute to this. So to address the first one, which was iron, it's unlikely that iron is the cause of this condition. So although iron deficient anemia and megaloblastic anemia can be comorbid conditions, iron deficiency is not the primary cause of megaloblastic anemia. Megaloblastic anemia is characterized by large, immature red blood cells, while iron deficient anemia leads to small or pale red blood cells and is caused by insufficient consumption or malabsorption of iron rather than B12 or folic acid, which is a lot more likely the cause here. As far as B6 goes, a B6 deficiency would cause some of her symptoms, but not some of the more important ones. B6 deficiencies would likely cause inflammation, particularly inflammation of the skin or dermatitis, and other skin presentations like rashes or greasy skin characteristics, in addition to some of the other symptoms she was presenting with, like numbness and tingling in the lower extremities. B6 deficiencies also typically result in changes in mood, confusion, and other neurologic symptoms. And outside of the numbness and tingling that she reported, she was testing negative for other neurologic conditions or changes in affect and mental health. So it's unlikely that B6 is the cause here either, which brings us to B12. Megaloblastic anemia is typically caused by a deficiency in vitamin B12 or folic acid. And this deficiency can be caused both by insufficient dietary intake of those things or by poor absorption in the intestines of these vitamins. Both B12 and folate are really necessary for the synthesis of DNA, and so deficiencies of these vitamins explains a lot of the symptoms that are experienced by this patient. Evidence currently suggests that in vitamin B12 deficiency, altered folate metabolism is implicated for some of these alterations in both purine and pyrimidine metabolism and results in impaired synthesis of thiamidolite and purine. If I were going to be testing this patient or running laboratory tests to confirm this diagnosis, I would run a complete blood count and vitamin B12 levels, as well as some other blood testing. In the event that that was inconclusive, the next type of laboratory test I would probably pursue would be a bone marrow biopsy and exam. So those are the cases that I presented on. Here's a list of my references. Please feel free to reach out if you have any questions or comments or want to discuss these cases further. And thank you so much for listening.